All right, can you see the screen?
Yeah.
Perfect.
Okay. Ready to start?
Yep.
So our topic is depression, and our group members are Tanaya, Megan, River, and Maya. Next slide, please. What is depression? Depression is a prevalent mental illness affecting approximately 264 million people worldwide and leading to about 700,000 suicides each year. It is characterized by a persistent low mood and a loss of interest in activities, significantly impacting daily life, relationships, and work. Depression is more than just an emotional issue, it can physically change the brain. Studies show that depression leads to shrinkage in key areas of the brain, including the hippocampus, which is important for learning and memory, and the prefrontal cortex, which plays a role in higher level thinking and decision making. In addition, the thalamus, caudate, nucleus, and insula also experiencing a shrinkage. These brain areas are involved in emotional regulation, sensory processing, and motor control. Furthermore, depression impairs neuroplasticity, the brain's ability to recognize and form new connections due to the harmful effects of high cortisol levels. Elevated cortisol suppresses neurogenesis and the growth of dendritic spines, leading to difficulties in memory, emotional regulation, and cognitive function. Next slide. Thank you. Right. Depression can manifest in various ways, and not everyone will experience all the same symptoms. The intensity and duration of these symptoms can vary from person to person. Some key signs are sadness, feelings of helplessness, hopelessness, irritability, loss of interest in activities, fatigue, and concentration issues. Additionally, depression affects sleep and appetite. Some people experience insomnia or sleep too much, and changes in appetite may lead to either weight gain or loss. Physical aches and pains like headaches, joint pain, or digestive issues are also common. Understanding these symptoms can help in recognizing depression, and it's important to seek help if you or someone you know is experiencing these signs. So,
So the neural basis of depression. So the brain regions involved in depression include the prefrontal cortex, which is the impaired emotional regulation, the amygdala, which is heightened emotional reactivity, hippocampus, which reduced volume affecting memory and mood, and the striatum, which decreased reward processing. Dysregulation of the HPA axis leads to excessive cortisol release and worsening symptoms. Key neurotransmitters involved include serotonin, which is mood regulation, dopamine, motivation and reward, and norepinephrine, which is alertness and energy, and the GABA, which is cognitive and emotional balance. So, my name is Megan, and I will be discussing the article on the longitudinal effects of cognitive behavioral therapy for depression on the neural correlates of emotional regulation. So, the specific question being asked in this article is how do the emotional regulation strategies of feeling versus analyzing influence brain activity when recalling negative memories in individuals with depression? So, some background is the study is focused on emotional regulation in individuals with depression, specifically how people with depression process negative memories. Previous research suggests that emotional regulation strategies, such as reappraisal or focusing on feelings, can influence how memories are recalled and how emotions are managed. However, less is known about how these strategies work in the brain, particularly in individuals with depression. So, what are the methods that are used to answer this question? So, the participants in the study included two groups, which were individuals diagnosed with depression and healthy controls. The setup was that the participants were asked to recall memories that were emotionally negative, so feeling sad, hopeless, or ashamed. And they were asked these questions during an fMRI scan. And participants used either the feel strategy, which is focusing on the emotions tied to that memory, or the analyze strategy, which is looking at the memory from a more rational and positive perspective. And then the task design is, it was divided into two blocks. So each consisting of analyze trials and one field trial and vice versa. Each trial involved a brief memory cue followed by either a feel or analyze instruction, and participants were asked to rate their emotional response and memory vividness. The task alternated between the memory trials and a baseline spatial perception task. So these are some of the results that were found. So these are the key findings. Significant differences were observed in the brain regions activated during the feel and the analyze strategies. Depressed participants showed different patterns of brain activation compared to healthy controls, particularly in regions associated with emotional processing and regulation, for example, the amygdala and the prefrontal cortex. The field strategy led to greater activation in emotional processing regions, while the analyze strategy was associated with more activity in areas linked to cognitive control. So the independent variable in this study was the emotional regulation strategy used, which is the feel or the analyze. And the dependent variable was the brain activity, so what was measured during the fMRI scan, and the clinician outcomes, which would be the BDI scores. So what is shown on the screen is the figures and tables found in the article. So in figure 3, the study shows the brain regions where depressed individuals had lower brain activity related to emotional regulation before they started CBT, which is cognitive behavioral therapy. The researchers used fMRI to compare two conditions, feel versus analyze, where participants either allowed themselves to feel the emotions or tried to regulate them by analyzing the situation. The results showed reduced brain activity in certain areas when participants tried to regulate the emotions. This suggests that before CBT, depressed individuals had difficulty activating these brain regions when trying to regulate their emotions. And then when you look at figure 4, which is on the right, it shows brain regions where greater reductions in brain activity during emotion regulation from before or after CBT were linked to better treatment outcomes. For example, lower depression scores at the end of therapy. The study suggests that successful emotional regulation, less brain activity in these areas after therapy, was linked to better depression outcomes. This might mean that CBT helped participants become more efficient at regulating emotions, requiring less effort from these brain regions over time. So here are some suggestions. The findings suggest that different emotional regulation strategies engage distinct neural circuits in individuals with depression. The feel strategy may heighten emotional experiences, while the analyze strategy may help to regulate emotions more effectively. These insights could be useful in developing targeted therapies such as CBT that focus on teaching emotional regulation strategies. So some unanswered questions is how might these findings generalize to other emotional experiences beyond sadness or hopelessness? And are there long-term effects of practicing these strategies on brain function and emotional regulation in individuals with depression? And lastly, some contradictions to previous findings. Some previous studies have suggested that people with depression have difficulty using cognitive reappraisal strategies, but this study shows that the analyze strategy can indeed engage brain regions linked to cognitive control and emotional regulation. This may challenge earlier assumptions that individuals with depression are less capable of using adaptive emotional regulation strategies. And that concludes my article that I chose, so I'm going to pass it on.
So my name is River, and I'll be doing the article titled Short-Term SSRI Treatment Normalizes Amygdala's Hyperactivity in Depressed Patients. Okay, so short-term SSRI treatment normalizes amygdala hyperactivity in depressed patients. The background, both behavioral and brain outcome measures show that antidepressant medications such as selective serotonin reuptake inhibitors create negative biases in emotional processing in depressed patients. Whether these effects precede or follow changes in clinical status is unclear. The effects of short-term selective serotonin inhibitors treatment on the amygdala response in depressed patients are examined in this paper. The study looks at whether SSRIs lessen the increased activity of amygdala in reaction to unpleasant emotional stimuli before any discernible mood improvements take place. Our study question is, before clinical mood changes take place, does short-term SSRI treatment normalize amygdala activation in depressed patients? Next slide, please. Methods used to answer the question. The study examines whether short-term SSRI medications such as acet acet escitalopram normalizes amygdala activation in depressed individuals prior to clinical mood changes using randomized placebo-controlled between subject design. Participants, there were 42 unmedicated depressed patients and 18 healthy controlled patients. The recruitment process was used by utilizing newspaper ads, and recommendations from clinics were used to find depressed people. Local ads and university volunteer lists were used to find the healthy controls. Inclusion criteria for depressed patients. Major depressive disorder is diagnosed using DSM-IV structured clinical interview, 3 weeks or 5 weeks, without using psychiatric medication at the moment. The exclusion criteria: psychotic disorders, substance dependence, suicidal risk, pregnancy, neurological disorders, history of axis I1 disorder for healthy controls. Next slide, please. Study designs and drug treatment. Double-blind placebo-controlled parallel group design. The randomized treatment assignment. Patients with depression were placed in one of two groups: 10 of escitalopram every day for 7 days is prescribed to this group. The placebo group, for 7 days, they were given a placebo. Healthy controls were merely scanned for baseline comparisons and did not get any medication. For mood and anxiety assessments conducted: one, Hamilton depression rating scale; two, Beck depression inventory; and three, the Spalberger state trait anxiety inventory. So next slide, please. Setup and function. Functional magnetic imaging was utilized to monitor amygdala activity in response to emotional stimuli. The task during the fMRI: one, participants quickly displayed both pleased and terrified facial emotions as part of gender discrimination challenge. Two, following 100 ms display of each face, there was a variable interstimulus time of 2,500 to 2,900 ms. Three, participants used MRI compatible keypad to determine each face's gender. Each patient went through a 8.5-minute scanning session while alternating blocks such as one, baseline fixation cross; two, happy facial expression; and three, fearful facial expression. Next slide, please. Obtain results. Placebo-treated depressed patients were found to have a higher amygdala activation to fearful faces than healthy controls. In the groups, there are no significant findings in the amygdala response to happy faces. Compared to patients receiving a placebo, those receiving escitalopram exhibited noticeable less amygdala activity in response to frightening faces. Normalization was suggested by the escitalopram's groups, amygdala's activity becoming comparable to that of healthy controls. Next slide, please. Okay, implications of findings and unanswered questions and limitations. According to the study's findings, SSRIs affect how emotions are processed before they result in noticeable mood enhancements. This is consistent with the cognitive neuropsychological model of antidepressant action, which holds that antidepressants enhance mood by challenging negative emotional biases. The main conclusion is that early in the course of treatment, SSRIs may influence the amygdala, which could lessen hyperactivity to unpleasant stimuli before patients experience a subjective improvement. This research lends to the theory that antidepressants alter cognitive and affective processes over time, resulting in mood enhancements rather than instantly improving mood. According to the study, assessing alterations at the beginning of the treatment may be helpful for estimating the effectiveness of antidepressants. Unanswered questions. So the first unanswered question is long-term symptom relief predicted by amygdala normalization? Only 1 week of SSRI therapy was used to study to detect changes in the brain. Whether early amygdala normalization predicts a later clinical response after a few weeks should be the focus of future studies. Question number 2. Do these side effects apply to all SSRIs or just the escitalopram? It's uncertain if other SSRIs or antidepressant classes would have the same early effects on the amygdala because only escitalopram was investigated. And number 3, are there any behavioral consequences of reduced amygdala activity? The study did not find any changes in task performance, such as gender, discrimination accuracy, and reaction time. Next slide, please. Contradictions with previous research. 1. According to certain research, people with depression, especially those with treatment-resistant depression, have reduced amygdala activity. One study, for example, discovered that patients have reduced amygdala responses during affect labeling tasks, and that this blunting was linked to severe depression. And then number 2, delayed versus early effects. SSRIs take weeks to show discernible benefits in mood, maybe because neuroplastic changes take time to occur. This is in contrast to research that indicates mood improvements may be preceded by early shifts in emotional processing. And then number 3, hyperactivity of the amygdala as a trait versus state maker. The question of whether amygdala activation is a state maker or a trait-like maker of depression is up for debate. According to some studies, hyperactivity during positive autobiographical recollection is a state maker that normalizes with symptom remission, but hyperactivity during negative recall is a trait-like maker. The question of whether amygdala activation is a state maker or a trait maker of depression is up for debate. According to some studies, hyperactivity during positive autobiographical recollection is a state maker that normalizes with symptoms remission, but hyperactivity during negative recall is a trait-like marker. This study provides strong evidence that SSRIs for amygdala function early in treatment, even before mood changes occur. However, it leaves open for questions after long-term relationship between early neural changes and symptom improvement. Thank you, and that was my article.
Hello, my name is Maya, and my report article that I will be presenting is called Structural Plasticity of the Hippocampus and Biological Psychiatry Amygdala Induced by Electroconvulsive Therapy in Major Depression. This article was published by Joshi et al. In 2016 in the Biological Psychiatry Journal. Next slide. Background. Within this article, it is noted that major depressive disorder impacts millions of people around the world. While major depressive disorder can be treated through different therapies and pharmaceutical medication, there are some patients that have to wait a while to feel the effects of the treatments, and sometimes they're not affected at all. Because of that, we have to look at different ways that could be improved. One of the things that has been noted within this journal is that the lack of volume and the shape of the hippocampus and the amygdala is found to occur during the first depressive episode period, and it loses volume as there are more depressive periods. So what can we do to get that back? It is noted that electroconvulsive therapy has been used previously in patients and it has shown great effects. However, what has happened is that within these research studies noted within this article, is that it did not make connections towards patients that have been using antidepressant medications with the electroconvulsive therapy. It didn't follow through that. So within this article, the research question was made, can electroconvulsive therapies respond better and improve that volume and the shape of the hippocampus and the amygdala in individuals that have major depressive disorder? Next slide, please. Methods. So participants were divided into the two groups. And one is with the patients that have major depressive disorder, and the other ones were known as the control subjects. So within that patients, there was 43 patients, 20 men and 23 women. The 35 patients, they were previously diagnosed with major depressive disorder, but 7 of those patients had bipolar disorder, but it still fall within that major depressive disorder surrounding what they examined. All of the patients that were found were from the University of California, Los Angeles, Resnick Neuropsychiatric Hospital. And they had to do previous psychological evaluations, and they were called the Diagnostic Statistical Manual of Mental Disorders. And when they were doing the evaluations to see if they follow within a major depressive disorder, they were verified within the many international neuropsychiatric interviews. So they doubled down to make sure that these patients followed within that research study. All of the patients had 2 or more depressive disorders for which they had to use 2 or more antidepressant treatments. And all of the patients had to, within the study, gradually limit taking the antidepressant medications 48 to 72 hours before taking the electroconvulsive therapy. Now, when we look at the control subjects, it's a little bit different. There was 32 participants. There was 14 men and 18 women. All were situated around the Los Angeles area, so they were all within the same area. They were also screened, but only for the mini international neuropsychiatric interview to see if they had any previous um, things or notes of depression, any previous past of those episodes. When they didn't do that, they were accepted. So one of the biggest things that should be noted is that all of them had written consent for the research, and they were also approved by the University of California, Los Angeles Review Board, and they gave that authorization. The patients within this study also had to follow one of the patients that were excluded from this study were if they only had one depressive episode, they had depression after the 50 years of age. They had multiple psychiatric disorders or dementia that took part in a nerve-related treatments within 6 months. So with all of that exclusion, these patients were picked. And within that, once that study was set up, the next process went into it. Next slide, please. So on the right shows the details of how the study was designed. And within that, it went on for the following ways. All the patients that were evaluated, they had to go through 3 different stages of time for electroconvulsive treatment. They had to have that treatment they had to be reviewed 24 hours before that, so that's T1, then 24 hours after the 3rd treatment, so they had few in between, and then during the 1-week period done 3 times, so in 4 weeks of total, as you can see on the right side of the picture, and that's T3. When the patients were evaluated, what they found was that all of them joined within the first part, so the T1. 36 patients at the end had second treatments, and then 29 patients had the full treatment at the end. When we look at the control subjects, all of the control subjects, 32, had the first treatment. 30 of the control subjects joined the second treatment, and then two stages were spaced out within the 5-week span. So what they tried to do was it would follow within the same timeline as the patients and the subjects, so that way they wouldn't differ from each other. The only patients that differ from it was that the ones that who didn't want to have electroconvulsive therapy or not wanting to be scanned with the magnetic resonance imaging. And they were spaced out so that they could fit within the 3 evaluation time stages. Next slide, please. So methods, the materials and assessments. On the left side is an example of an electroconvulsive treatment that was used called the 500 Mecta-Corp model. So this was the model that was used on the patients. They also had to do the response measurements. So what they did was they did the Hamilton Depression Scale to see how they're feeling before and during and after the treatment. And then the Montgomery-Åsberg Depression Rating Scale. So they had to follow what the patients and the control subjects were feeling to know if the research is showing any improvement or not. Also, the quick inventory depressive symptomology. So it was a self-report. The image of the brain was done by Siemens Allegro system and FreeSurfer version 5.30 software to see what areas highlighted when reacted when they were doing the electroconvulsive therapy. Within that therapy, it was done 3 times per week, the treatment. They were given the patients applied general anesthesia. It was called a methotrexate 1 milligram, and they used certain areas to paralyze so that way they wouldn't feel the pain. The brief pulses were generated on the right unilateral lead placement and bilateral lead placement. 32 patients had it on the right unilateral lead placement. 9 patients had a mix between the two, and then 2 patients had bilateral lead placements. All of them were assessed, and within these images, they were able to see the reactions within the amygdala and the certain areas that will be noted ahead. Next slide, please. So the results. On the right, there are 2 results, and these were longitudinal studies that were done. So basically, what happened was on the left side of the picture is the patients, and on the right is the control groups. What was found is that the long-term effects of the electroconvulsive therapy was seen. Patients had So the patients had more of a reduced volume in the right hippocampus compared to the control subjects, but it grew in the beginning. But then the volume on the left and right hippocampus increased to the patients every stage as it gone. For the control subjects, on the other hand, the volume didn't change much during the 2 times that they had the stages. The patients, how they were able to reflect on that is the patients reflected it through completing the Hamilton Depression Rating Scale and the Quick Inventory Depressive Symptomology Scale self-report, and they were able to see how their symptoms got better at each of the treatments. Next slide. Now, seeing how the brain reacts, you can see it on the left side. There were long-term effects with the electroconvulsive therapy on the patients. That what was seen, so with, for instance, the hippocampus, that's the first image on the left. In the 3 stages, the right frontal hippocampus altered and developed more for the patients. Most of the changes occurred again within the 3rd stage. Changes appeared within the dormedial and the left bilateral amygdala. And then within this 3rd stage that happened as well, the left basolateral amygdala developed the most. So as the stages got more and more, the development of the volume of the brain changed. And this is how it looked like when it approved. There was reactions to it and there was more volume within it. Next slide. Discussion. So when we look at the electroconvulsive therapy, we look at it and analyzing the hippocampal formation and its volume that could be treated guideline for electroconvulsive therapy. The changes in the hippocampus and amygdala occurred immediately during the middle and then the end stages of the electroconvulsive therapy. Patients were given limited amount of, they were told not to use much of their antidepressants because they wanted to see the reactions of that. But before the electroconvulsive therapy, and it did affect the volume within those areas. Much of the volume changes did occur in the hippocampus with the electroconvulsive therapy, but it also happened in the right hemisphere within that brain. Examining the hippocampal formation and its volume beforehand was needed within this. Next slide. Conclusion. What could be looked on within this article? Electroconvulsive therapy could be used to lessen the major depressive disorders that are impacted with how hippocampus and amygdala was shaped or how it responded. It did show that the diminished hippocampus and amygdala volume, it expanded and enhanced when it was used within electroconvulsive therapy. What the question remains is, will the future research focus more on the electroconvulsive therapies and the effects of it on the amygdala formation, plasticity long term? But the focus is placed, will the treatment be reactive and could it be sustained with it as a good treatment? And also if there's a possibility if relapse can occur even using the electroconvulsive therapy. These things are noted, but it does reflect that electroconvulsive therapy can actually improve major depressive disorder. And this concludes my presentation.
Hi, my name is Tanaya Hibbert, and my article was The State and Training Effects of Mindfulness Meditation on Brain Networks Reflect Neuronal Mechanisms of its Antidepressant Effect by Yang et al. Next slide, please. Okay, so research has shown that depression is linked to abnormal brain connectivity, particularly in the default mode network, which is involved in self-referential thinking and rumination. The background and objective of this study is that it is investigating how mindfulness meditation influences brain plasticity and its potential antidepressant effects. The focus is on changes in resting state, functional connectivity, RSFC, and meditation state brain activity. Traditional treatments for depression include medication and psychotherapy. There has been growing interest in alternative and complementary therapies, including mindfulness meditation. Mindfulness meditation is a practice derived from Buddhist traditions that involves focusing on the present moment in a non-judgmental way. Next slide, please. Study background. Mindfulness meditation, as said earlier, is derived from Buddhist practices. It is shown to help regulate emotions and is used in a clinical setting to treat anxiety, depression, and addiction. Neuroimaging studies indicate that medication can alter brain activity, but the exact neuronal mechanisms remain unclear. The study aims to examine how meditation training affects brain connectivity and depression-related symptoms. Previous research has shown that mindfulness meditation has several benefits, particularly in emotional regulation. Studies have suggested that practicing mindfulness can lead to reduced stress and anxiety, increased emotional resilience, and improved cognitive function. However, while neuroimaging studies have shown changes in brain activity, the exact neuronal mechanisms remain unclear as stated earlier. The gaps that are going to be addressed in this study are how mindfulness meditation affects brain network connectivity in individuals who are new to meditation and whether these changes correlate with reductions in depression and anxiety symptoms. Next slide, please. Methodology. The study was conducted using longitudinal design, meaning that participants were observed before and after meditation training to track changes over time. There were 13 participants that were university students, all of whom were new to meditation. They completed a 40-day mindfulness meditation program, practicing for about 10.67 minutes per day. For brain imaging, there was a functional MRI scans that were taken before and after the meditation training to analyze changes in brain connectivity, and the psychological assessments. Researchers used standardized self-report questionnaires. This CSD scale to measure depression systems, and the State Trait Anxiety Inventory STI to measure anxiety levels. By comparing the participants' brain scans and psychological assessments before and after the meditation program, the researchers were able to determine how meditation influenced brain function and mental health. Next slide, please. Results in the changes of the brain. The results show that mindfulness led to significant changes in brain connectivity. Specifically, there was increased functional connectivity in the precuneus and temporoparietal junction, TPJ. These areas are associated with attention, self-awareness, and emotional regulation. There was decreased connectivity in frontal brain regions, particularly those linked to rumination and self-critical thinking, which are commonly overactive in people with depression. The study also found changes in the DMN, the brain network involved in self-referential thoughts. This suggests that mindfulness may help reduce excessive self-focus and negative thinking patterns seen in depression. These findings indicate that meditation actively reshapes the brain, improving emotional regulation and reducing depressive thought patterns. Next slide, please. Results, psychological effects. In addition to brain connectivity changes, the study also found significant improvements in participants' mental health. Depression scores. Before the training, the average SEST score was 16.23, which is slightly above the clinical threshold for depression. After the training, the score dropped to 9.0, a nearly 50% reduction in depressive symptoms. Anxiety scores. Participants who also experienced a significant reduction in trait anxiety after meditation training. Tension reduction. There was a notable decrease in reported tension levels, which aligns with the observed changes in brain connectivity. These psychological improvements suggest that mindfulness meditation can be an effective tool in reducing depression and anxiety symptoms. Next. Neuroplasticity and depression. One of the key takeaways from the study is that mindfulness meditation promotes neuroplasticity, the brain's ability to reorganize and form new neural connections. The practice strengthens prefrontal cortex control over emotional regulation. It reduces hyperconnectivity within the DMN, which is often overactive, and the results indicate that the observed brain changes correspond to the improvements in depression. This means that meditation can be used to train the brain to function differently. Next slide, please. Thank you. And limitations in future research. While the findings from this study are promising, there are some limitations that should be addressed. There was only a small sample size of only 13 participants were included, which limits the generalizability of the results. There was no control group. Without a non-meditating comparison group, we can't rule out the possibility that other factors contributed to the observed changes and that it was a short duration. The study only lasted 40 days, so we don't know whether these effects are long-lasting. Future research should include a larger and more diverse samples, use randomized controlled trials to better establish causation, and explore long-term effects of meditation and brain plasticity. Next slide. Conclusion. In summary, this study provides strong evidence that mindfulness meditation can alter brain networks and reduce depressive episodes. Participants showed functional connectivity changes in key brain regions linked to depression. Depression and anxiety scores significantly decreased after meditation training, and the results suggest that mindfulness meditation may be an effective therapeutic tool for mental health treatment. While more research is needed, these findings support the growing use of mindfulness meditation in clinical psychology for treating depression and anxiety. Next slide. Okay, and that's all. Here's our references, I believe. Or is there more? No, that's all.